I'm Harriet Van Spal, cardiologist from McMaster University, and I'm so delighted to have Dr. Mark Petrie from Glasgow. Welcome.
Thanks very much. Delighted to be here.
We are here at HFA 2024 to talk about some of the highlights from this meeting. So Mark, your group presented a couple of trials. Do you want to start off with the STEP-HFpEF sub-study?
I would love to, Harriet. So the STEP-HFpEF trial was a trial. Well, first of all, there was two trials, one in people with HFpEF with obesity phenotype and diabetes, and the other one in obesity HFpEF without diabetes. So what we did is we put the two trials together and we looked at the effect of semaglutide on N-terminal-proBNP, the heart failure biomarker. And what we did, so we were anxious about the results of the STEP-HFpEF trial because if people lose weight by diet or exercise, their BNPs normally go up. So we were anxious that we would show the same with semaglutide and people might misinterpret that as heart failure worsening. So we anxiously saw the results, and to our delight, the BNP went down, not up. So our interpretation of that as investigators is that we improve the heart failure status of the people with obesity-related heart failure. So we were punching the air and delighted to have a signal. And it's also, the context is important because we also, if you remember, the clinical events in STEP-HFpEF, there was very small numbers, but it favoured semaglutide compared to placebo. So marrying the clinical events and BNP, we think that gives a logic and rationale to lots of new trials with GLP-1 drugs and related drugs and big outcome trials in the future.
Right, and a hint that there might be better treatment effect in patients who had higher NT-proBNP levels at baseline based on the tertile analysis, is that right?
Yes, so exactly. So people with higher baseline tertiles had more reduction, or so more improvement in quality of life, but also as a continuous variable as well. We did both analysis. So people with higher BNPs had greater improvement in quality of life. So again, that really steers us towards thinking that people with maybe bad heart failure have more to gain from these drugs, which is probably good news for heart failure.
Right, and then there was the IMPACT-MI RCT sub-analysis looking at treatment effect in people with diabetes versus no diabetes. You were involved in that trial. Do you want to give us the synopsis?
Yeah, so just to rewind very briefly, IMPACT-MI was looking at empagliflozin against placebo post-MI. And this was quite controversial because the DAPA-MI investigators felt it was unethical to include people with diabetes in their trial, but in IMPACT-MI we took people with heart attacks, both people with diabetes and without diabetes. So the analysis presented here showed that people benefited equally whether or not they had diabetes in terms of heart failure hospitalization. But of course, just to be clear, mortality was not reduced, but heart failure hospitalization was. So again, reassuring information that the people with diabetes benefited in the same way. There was a slight signal towards more benefit in people without diabetes, although the interaction p-value didn't suggest that was a very firm conclusion to draw.
Yeah, and given the breadth of evidence to support the use of SGLT2 inhibitors in patients with cardiovascular risk factors, heart failure, CKD, this trial, while the primary treatment effect was neutral, gives us important safety data that you might as well get on with it, treat people regardless of whether they have diabetes or not, and then the long-term benefits accrue, particularly with regards to heart failure, hospitalization.
Just, I think that's an excellent summary of where the trial takes us to, and the safety data is really crucial because, again, people are anxious about hospitalized use of these drugs, where they used to be, so there's more reassurance about that, but also in the context of myocardial infarction, reperfusion, contrast, starting lots of other drugs. So it certainly gives us excellent safety data, but also rationale for using it in people who have these other indications which you've outlined.
There was another small one-center trial that I thought was innovative because it highlights the role of multidisciplinary healthcare workers in the management of acute or decompensated heart failure. Do you want to touch upon that? I'm talking about the nurse-led decongestion trial.
So I love to see that because, again, heart failure teams, certainly in our world, pivot around nurses. The nurses they're not just peripheral, they're the core of our teams. So designing trials around nurse interventions is brilliant. We did this 20 years ago in the original heart failure nurse trial, so seeing this taken forward into inpatient heart failure management is brilliant. So having the nurses looking at urinary sodium is fantastic.
Right, and there was a really nice point of care device that nurses used at the bedside. Tell us about that.
Yeah, so it looks like it's easy to use and easy to interpret, and just it would fit globally. So I love the look of it, and I think it answers that question, because when you talk about measuring urinary sodium, people think, oh my, I've got to have to send it to a lab or get it back again and wait for the results. So to have something accessible in a ward is great. So I think the concept certainly is good of the device, and also to have it done by nurses. So I can see a lot more happening in the future with that, and certainly all of the other things happening around urinary sodium. There's many people interested, but the penetration globally is normally in the hands of enthusiasts. I think this sort of thing would allow it to be more generalizable and be used by normal heart failure teams. So I'm pretty enthusiastic about that.
Right, so in this trial, if the urinary sodium at the point of care was over 70, then the IV diuretic regimen stayed unchanged. Otherwise, the nurse doubled the dose. And it demonstrated that this strategy increased natriuresis, which was the primary outcome, further worsening in renal function or in hypokalemia. So potentially safe in the context of a 60-patient trial. Pause to consider using this kind of innovation to optimize care. Now, patients who were on a diuretic dose of over 80 milligrams of IV furosemide were excluded from participation, so that's another caveat. But further exploration is certainly warranted, I think, in a multi-center setting.
It's a great first step, but the concept's great, and certainly will prompt other people to do other things in the area. So exciting stuff.
Right, and then there were lots of different study designs beyond RCTs. I'm not sure if you want to touch upon a registry or two that struck your mind, and if you don't, then I will chip in.
So I didn't see too many registries. I saw some meta-analysis that were interesting, but the registries, I didn't see too many of them. So.
Okay, so tell us about the meta-analysis you're referring to.
So we saw a really interesting meta-analysis this morning looking at finerenone, so non-steroidal MRAs across the Fidelity program, but also in fine arts. And the investigators had looked at these really large numbers of patients across these programs and trying to look at how the different chronic kidney disease and metabolic comorbidities processes overlapped, and really to highlight that although we think in terms of CKD trials and HFpEF trials, a lot of these patients cross over between the different trials. So looking at the baseline characteristics of these trials, but also looking ahead to using the wealth of data to look at endpoints beyond individual trials, so things that all-cause mortality. So I think merging different data sets inform us about the profile of the patients, so in a kind of registry way, but also to knock on to learning more about endpoints. So that was pretty interesting. But the registries, I've got to say I missed them, so maybe you can update me.
Okay, well, this wasn't a registry, but it was a pooled analysis of a trial that my group led, where we looked at...
HF.
That's it.
Excellent.
More than 4,000 patients who had enrolled as part of the PACT-HF randomized control trial. And we actually looked at sex differences in 5-year clinical event rates, healthcare utilization, and healthcare costs. And we demonstrated the very high risk of mortality that these patients are at. So about 65% of patients were dead within 5 years. About 85% had been rehospitalized, typically multiple times. And these rehospitalizations drove up healthcare costs and accounted for a majority of the annual healthcare costs, which we estimated at around 80,000 Canadian dollars, and these are just the direct costs of care. There were no sex differences in mortality, readmission, or total healthcare costs, but we demonstrated sex differences in the kind of healthcare encounters that people had, whereby males received more invasive care, more specialist care, and more heart function or heart failure disease managed care, which we know improves outcomes. Whereas females received more supportive care and spent more of the healthcare dollars in sort of nursing home or rehab type establishments.
There's quite a big difference in those, wasn't there, between the sexes?
Yes, and it may be in part due to the difference in age, where females are older than males by about 5 years, but gives us pause to consider that they're both at an equal risk of death and readmission, and yet we offer more specialized care to males. So some work to do. I thought there was an interesting registry. Well, it was actually a pooled analysis of 4 existing cohorts, where there was an analysis looking at the TTR variant V1421. And this affects about 3 to 5% of Black Americans. And the analysis, I thought, was interesting because it highlighted that females and males are at the same risk of mortality and heart failure readmission. We often consider this to be a man's disease. And that the cause of heart failure readmission was often in the setting of HFrEF in amyloid rather than HFpEF. And that the survival, there were a number of life years lost because of this underlying genetic variant. So an interesting use of existing data sets to highlight a unique genetic cause of TTR amyloid.
I think there's a long way to go in TTR amyloid. Obviously the genetics of it is fascinating, the gene therapy's potential is fascinating and starting to be explored as well. So these kinds of analysis are just eye-opening. And actually the whole amyloid field has taken us way beyond the amyloid area, to be honest. The things they're doing, the science behind the whole field is mind-blowing, to be honest. And I thought those data were fascinating and just make you think, because things that are happening in the amyloid field could easily happen in other causes of heart failure. Obviously we're learning more about the genetics of HFrEF and the potential therapies around the genetics of HFrEF. And nobody's even thinking about HFpEF as a group in genetics, but coming from the amyloid angle, that's also fascinating. So the difference in outcome, I'm sure in 5 or 10 years, once we see large registries, we understand amyloid more, the genetics as opposed to the wild types, the whole area will understand the natural history, the intervention. So it's just really exciting to see that at this meeting. Is great to see these important data presented to the HFA.
A burgeoning field that makes us consider all of the other cardiomyopathies that are relatively neglected and which have room for knowledge generation. And perhaps we'll end with the Dutch registry of just over 4,000 patients with heart failure. And it investigated de novo and chronic heart failure and the uptake of guideline-directed medical therapies, which is of relevance to both of us. I know we both are involved in trials.
We're passionate about it.
Yes, absolutely. And the uptake of therapies overall was not bad. 44% were on quadruple therapy. These are people with HFrEF. But only 1% achieved target dose therapies across those 4 classes. And people tended to be on better therapies when they were receiving care from these nurse-led clinics, which was interesting, versus usual care delivered by people like us. So it highlights again the role of the multidisciplinary care team in both delivering great care and delivering efficient care, because you can extend.
I could have said in our practice, if you're looked after by me, you're also looked after by a nurse, because I do my heart failure clinic with nurses and pharmacists together. It's not we're a team. Medicine for the elderly, palliative care, we're all together. So our service is a service, and to be honest, the nurses and pharmacists do 97% of the titration. The cardiologist does more of the investigation of the heart disease, and we work very much as a team. So our nurses are guilty for all the excellent care. Responsible.
We use guidelines. We have a lot of heart function clinics in Canada, but not enough, because to date the majority of patients receive care from generalists. And heart function clinics, or these disease management programs with multidisciplinary care clinicians, are beyond the reach of many people based on their geography and their proximity to an academic center, which gives us reason to consider other models of care that could extend reach to rural and remote regions, right?
So I think for us, the REF patients are in the cardiology services with the nurses and pharmacists. HFpEF is a whole new area, because people with HFpEF are in the general clinics, they're in primary care, they're in elderly people's homes, they're everywhere, so we're barely scratching the surface of HFpEF management. We do have a HFpEF service recently set up, but that's a novel thing with a particular design looking after HFpEF patients.
Fantastic. Well, thank you so much for being a lively discussant and for donating your time to be here with me.
Totally delighted to do it, to be honest. Very interesting, and thank you for updating me about some of the stuff I'd missed, so I hope everybody else enjoyed that as well.
We both updated each other. Thanks, Mark.